So hello everyone, welcome to my new video. So today's topic for discussion is on uveitis. Okay, so let's start. So uveitis, it is simply the inflammation of uveal tissue of the eye. So uvea is having three parts, right? Iris, ciliary body, choroid. These three together make uvea. So inflammation in any part of uvea can lead to uveitis. Okay, it can be inflammation of iris known as iritis. It can be inflammation of ciliary body known as cyclitis. It can be inflammation of choroid that is known as choroiditis. So this is the types of uveitis. So uveitis having four types: anterior uveitis, intermediate, posterior, and panuveitis. So anterior uveitis, that means inflammation of uvea limited to only anterior chamber. That is anterior uveitis, right? If inflammation of uvea is only limited to pars plana, that is intermediate uveitis, and if uveitis is beyond pars plana, this is posterior uveitis. And all these three together happen at one time, it is called panuveitis. So anterior uveitis types are iritis and iridocyclitis. Iritis means inflammation of iris. Iridocyclitis means inflammation of iris as well as inflammation of ciliary body. So ciliary body having two parts, right? Pars plicata and pars plana. So pars plicata, inflammation of pars plicata is under anterior uveitis. Inflammation of pars plana is under intermediate uveitis. So this classification is based on pathological classification where uveitis is two type, granulomatous and non-granulomatous uveitis. So when we will call the uveitis is granulomatous, if uveitis is due to any infection like TB, sarcoidosis, it is granulomatous. If uveitis is due to any immune reaction, it is non-granulomatous uveitis. So in this video, we will only discuss about anterior uveitis because it's also very big part, right? So anterior uveitis include iritis, iridocyclitis and cyclitis. So this picture will tell you all the parts of anterior uveitis. Iritis means inflammation of iris. Iridocyclitis means inflammation of iris as well as ciliary body. That means pars plicata area. And cyclitis means inflammation of this part. That is inflammation of pars plicata. That is cyclitis. Okay. Now if I say about the clinical features, then symptoms, that means what the patient will tell you. There is pain, redness, photophobia, defective vision. Okay. And what the signs that you will see during the slit lamp examination as well as workup, that is altered visual acuity, that is reduction of visual acuity. You will see circumcorneal congestion. You will see changes in pupil. You will see changes in iris. You will see changes in cornea. You will see changes in anterior chamber as well as lens. So we will discuss each and everything separately. Okay. So let's start from pupil. In case of uveitis, pupil is small and sluggish reacting. And you can compare the reaction of pupil by comparing the pupillar reaction with the normal unaffected eye. Okay. And normally what happen that iris and lens touch together in normal condition, but they do not cause or do not lead to any synechia formation. But if there is inflammatory reaction is going on, then due to the toxicity, like inflammation of iris is happening, then the attachment between the iris and lens become more. So it is leading to synechia, that is posterior synechia. That means iris is attached to the lens anterior surface. So it is called as posterior synechia. So that's why in case of uh, primary stage of uveitis, we prefer to give the patient cycloplegic drugs. Why? Because if we give cycloplegic drug to the patient, then pupil will dilate and it will break the synechia. So this is why cycloplegic drugs are given. So here you can see this is the posterior synechia formation here, but this part is having synechia, but this is not having synechia, right? And this is not having true synechia, but here it is synechia formation. This is the posterior synechia. right? But some parts are not attached and some are attached. So this is called as festoon pupil, okay, where some parts are attached, some are not attached. So it is creating an irregular pupil size, that is called as festoon pupil. And if this festoon pupil leads to a long period of time, it will lead to formation of synechia 360 degree, okay, that is called as ring synechia. Okay, so this is the flow chart where posterior synechia happen, and you will give cycloplegic like atropine or cyclopentolate depending on the patient condition. It will break the synechia and synechia will not happen. But suppose you give atropine in a late stage, then it will not able to break the synechia and it will form the festoon pupil. And if festoon pupil leads to long period of time, it will lead to ring synechia formation. And this ring synechia means there is 360 degree, there will be 360 degree, what to say, synechia formation like this picture. So due to this 360 degree posterior synechia, aqueous humor which is getting produced by ciliary process will not able to drain to the anterior chamber via the pupillary pathway because of the 360 degree posterior synechia. So it will locked in the posterior chamber. So this is why it will create some additional pressure on the iris, and iris will bow towards forward, leading to shallowing of the anterior chamber. So this bowing iris is known as iris bombay. Okay, so it is also known as occlusopupil. Before that, this is the picture where I was telling that if you observe the patient is having synechia, you will give cycloplegic drug to break the synechia. So once the pupil will dilate and break synechia, but some part of iris pigment are present in the lens. So this is how it look like. So we were talking about iris bombay, right? So due to this 360-degree synechia formation, aqueous not able to come to the anterior chamber due to the 360-degree posterior synechia, leading to bowing of the iris forward, leading to anterior angle closure. So it is a risk factor for secondary angle closure glaucoma, right? And due to the prolonged stage of anterior bowing, it lead to peripheral anterior synechia also. That means attachment in the angle. So it will also lead to aqueous humor outflow obstruction, right? As well as aqueous is already creating pressure in the posterior chamber. So all these things are making the patient in the risk factor for developing glaucoma. Okay, so that's why uveitis is a very big risk factor for glaucoma patient. Now this is the posterior synechia. So this is the gonioscopic view where you can see the segmental synechia formation in the angle. So this is the posterior synechia formation. Now if I tell about the nodules of the iris, then there is two type of nodules you will see. One is Kopis nodule that is present in the pupillary margin, and Busaka nodule present in the crypts of iris. Okay. And if I go to the changes in cornea, what are those changes that you will see in cornea? So you will see keratic precipitates. So these are the deposition, pigment deposition on the endothelium layer of the cornea. So normally the endothelium is very much tightly packed cell. That's why the iris pigment not able to attach on the endothelium layer. But due to the toxicity, some endothelium cells also damage, and in that part, these iris pigment get stuck and leading to formation of a triangular shape that is known as Earl's triangle. So depending on the type of kepi, you can say whether it is granulomatous or non-granulomatous. Like if it is small and medium sized kepi, it is non-granulomatous uveitis. If you see mutton fat kepis, then it is granulomatous uveitis. And in case of fresh kepi and in case of old kepi, how you will differentiate by looking at their margin and color. So margin, if it in case of fresh kepi, you can see the margins are very much prominent and color is not that much faded. But in this picture, margins are blurry and these are dull appearing. So this is the old kepi, right? So old kepi presence indicate it is chronic stage. Okay. Now, if I tell about the AC changes, anterior chamber changes, then two things you will observe. One is aqueous cells, another is aqueous flares. Cells are the precipitation of WBC in the anterior chamber. So you need to see the AC cells, you need to make the room dim, and you need to use the slit lamp direct illumination conical beam process, where the size is actually 1 by 1, and you need to focus just behind the iris area and see with the highest magnification, and you will see the floating cells in the aqueous. So you will grade these aqueous. There is a grading system. There is known as SUN classification, right? There is standardization of uveitic nomenclature. So depending on the sun classification, you will grade like whether there is +1, +2, +3, +4 cells. +1 means 5 to 10, +2 means 10 to 20, +3 means 20 to 50, and +4 means greater than 50. So this is how you will do grading of cells. After that, you will also observe flares. Flares are the protein deposition on the aqueous, that is anterior chamber. So these flares will also having its grading system like +1, +2, +3, +4, depending on the visibility of the structure, right? And this protein will also get deposited on the anterior chamber, leading to formation of hypopyon, right, as well as Kepi's formation and circumcorneal congestion you are seeing. So these are the changes that happen in the eye, as well as due to the toxicity of aqueous humor. When the lens absorb aqueous humor as the nutritional source, the toxin get inserted to the lens, leading to formation of opacity, and it will lead to cataract formation. So uveitis leading to formation of secondary cataract. Okay, so if I tell about the complication, then secondary glaucoma is a complication that I told here due to the iris changes, band shaped keratopathy, and thysical bulbi. So thysis bulbi, why? Because in the initial stages, when iris bombay will happen, IOP will rise eventually. But in the long stages, when this inflammation will lead to ciliary process, then there is reduction of aqueous production. So IOP will get produced in a less manner, leading to lowering of intraocular pressure. So it will ultimately lead to formation of thysical eye. There is a shrinking of eye. So this is anterior uveitis. Thank you so much. And in the next video, I will discuss on the investigation and treatment procedures. Thank you.